Okay, so we'll continue with the treatment. So as I told in respiratory system, this is how you identify that it could be a probable case of COPD exacerbation. So what emergency management you will start? So as I already told you, we are going to give a bronchodilator. So basic thing consists of giving a nebulizer, injectable bronchodilators like Berifilin, steroid. I'll tell the dose of each of these shortly. Then giving oxygen. Suppose if oxygen fails, then we have another system, non-invasive ventilation or intubation. So we'll finish shortly this one because this will be the basic management for bronchial asthma also. So we are going to give a nebulized bronchodilator. So commonly, ipratropium plus salbutamol combination is used, comes as Deolin, so that we can nebulize. So they say we can give a prolonged nebulization, like even up to 15 minutes, you can continue nebulization. Sometimes in the initial 1 hour, with a 10 minutes gap, every 15 minutes, you can give a nebulization. So which means you can give up to 3 nebulizations in 1 hour. That is accepted. So most of the time, patients will settle with 1 nebulization, but sometimes we may need to give few of these things. So this is the mainstay. Sometimes because Deolin is basically 2 bronchodilators, salbutamol and ipratropium. So you have known salbutamol is a short-acting beta agonist. Ipratropium is another bronchodilator. It is a short-acting muscarinic agonist. SABA and SAMA. We'll discuss about it sometime later, but just remember the name. SABA plus SAMA is the bronchodilator of choice in COPD. Sometimes we can give an inhaled bronchodilator also. So budesonide or beclomethasone, any other. I think budesonide is commonly available. All right, so this is the inhaled nebulization. Then comes the injectable bronchodilator. So Derifilin is the usual injectable bronchodilator. Some say that it's not commonly used nowadays because of the high chance of arrhythmia. But still in acute setting, especially in poor resource settings, Derifilin is still available. So 1 ampule comes as 2 ml. 2 ml contains 220 milligrams of Derifilin. So we can give 220 milligram IV stat. So it's usually diluted over 5 ml and given as slow IV. Suppose in elderly patients, if you are having doubt that this may cause arrhythmia or tachycardia, because patients in acute exacerbation still usually come with the tachycardia. If you give Derifilin, it can aggravate the tachycardia. So you may need to give a lower dose. So maybe you can give 1 ml, that is 110 milligram alone, you can give as slow IV. But most of the time it gets needed. So Derifilin can be given. Next comes is steroids. Steroid is the most important drug to be given in bronchial asthma. But even in COPD exacerbations, systemic steroids help. So usually we have 2 preparations. So since we are dealing with emergency, I think the best preparation to give is hydrocortisone. Double dose of hydrocortisone, because 100 milligram hydrocortisone we give commonly, but 200 milligram of hydrocortisone IV stat is the dosage of choice. Because if you give dexamethasone is a strong anti-inflammatory than hydrocortisone, but still dexamethasone takes time to act. So in the emergency, I think hydrocortisone will be a better preparation than dexamethasone. So injection Derifilin 220 milligram IV stat, injection hydrocortisone 200 milligram IV stat, nebulizer Deolin, like every 15 minutes you can repeat. Maybe you can nebulize of budesonide. You can keep oxygen. So next step is oxygen. So by this time, your ABG analysis would have been ready. So when to use oxygen, when to go to the next modality of respiration. So usually it comes like this. Oxygen, if it fails, we should go for non-invasive ventilation. If it fails, you should go for intubation. So respiratory cause of respiratory distress is called as respiratory failure, right? Usually respiratory failure is of 2 types. There are 4 types of respiratory failure, but I think it is enough if you know about only 2 types of respiratory failure. Type 1 respiratory failure or a type 2 respiratory failure. Type 1 respiratory failure is only low oxygen. Type 2 respiratory failure is low oxygen with a high carbon dioxide. So again, I'll tell this as a small side note because this is one important concept to remember. So as you know, respiratory system comes like this, right? Trachea divides into two bronchus, divides into many other subdivisions. Then we have the lung. So we have the alveoli within that. So the main function of all these airways. So the respiratory system grossly is divided into two things. One is the airways. Next is the lung parenchyma. The function of the lung parenchyma is to exchange oxygen with carbon dioxide. Whereas the main function of airways is just to conduct oxygen and carbon dioxide into the respiratory system. So what they tell is the airways have the main role of pushing carbon dioxide out and taking in oxygen, whereas the main function of lung parenchyma is to make the body get oxygen. So if there is a problem with the lung parenchyma, it usually causes only low oxygen, which is called as type 1 respiratory failure. So type 1 respiratory failure is also called as hypoxic respiratory failure, or you can mention it as an exchange failure. And it is a problem with the lung parenchyma. Whereas type 2 respiratory failure is opposite. It is a problem with the airways. This is called as ventilation failure. Ventilation is the process of taking in oxygen and leaving out carbon dioxide. So type 2 respiratory failure is called ventilation failure, or it's called hypercapnic respiratory failure. Or high CO2 is the main problem. Hypercapnic respiratory failure. So in type 2 respiratory failure also we'll have low oxygen, but the characteristic feature is we'll have a high carbon dioxide. So why I told this side note is, in the case of COPD, if they come with exacerbation, remember COPD and bronchial asthma are diseases of the airways, right? Bronchial asthma is a reversible obstruction of the airway. COPD is a permanent obstruction of the airway. Whereas, can you name some parenchymal lung diseases? Like it could be a lung fibrosis. It could be a lung fibrosis, pulmonary edema, pneumonia. All these are parenchymal lung diseases. So which means if a patient is having any of these diseases and respiratory distress, it is enough if we give oxygen. Oxygen is the main therapy here. If oxygen fails, if oxygen is not able to give sufficient respiratory support, only then we have to go to the non-invasive ventilation. As you know, non-invasive ventilation is not only giving oxygen, it is also removing carbon dioxide. Whereas, if patient is having type 2 respiratory failure from the beginning, example in COPD exacerbation, instead of giving oxygen initially, we can prefer non-invasive ventilation initially, right? In some cases of COPD or bronchial asthma who are controlled, who are previously well controlled, sometimes only low oxygen may be the thing. So in the case of mild COPD or bronchial asthma exacerbation, it may be enough to give oxygen alone. But in full-blown type 2 respiratory failure or example of COPD exacerbation, we may need to give NIV. So this is how you decide on the spot whether to give oxygen initially to the patient or whether you should start the non-invasive ventilation for the patient. Initial high carbon dioxide or a type 2 respiratory failure, start carbon dioxide, start non-invasive ventilation. If there is only a hypoxia and if the disease you are suspecting is a parenchymal lung disease, start oxygen initially. So this is the initial one. Suppose if oxygen fails initially, you have to switch over to non-invasive ventilation. Okay, so we have started the first example for respiratory diseases. So while discussing about COPD, we have discussed about the bronchodilators nebulization. So this is the initial thing. So after that, we can follow up. We can look for the blood reports, find out the cause which triggered the COPD exacerbation, whether it is infective or non-infective. If it is infective, start antibiotics. So the next step will go as such. And suppose if the initial thing fails, so we are given oxygen, derifilin, steroids, still the patient is having a wheeze or still COPD is present, then for refractory wheeze, what are the options? I think this is very important because this is also comes in emergency medicine. So even after derifilin, steroids, 1 hour of nebulization, and maybe non-invasive ventilation, still the patient is dyspneic. We have some few second line drugs. So one second line drug is injection magnesium sulfate. So injection magnesium sulfate comes as 1 gram in 2 ml vials. That is 50% solution. 1 gram of 50% magnesium sulfate in 2 ml it comes. So you can give 1 to 2 grams of magnesium sulfate in 100 ml NS over 10 to 15 minutes. So this can help in refractory wheeze. Then you have another injection called as injection aminophylline. So this is the advanced infusion version of derifilin. So they say you have to give 250 milligram of aminophylline IV stat followed by 50 milligram per hour of infusion for the next 5 hours. This may help. So these are the next options. Some say for bronchial asthma, we give another injection called as ketamine. Ketamine is an anesthesia drug, but usually we don't come to this level. I think it's enough if you remember only till aminophylline. So this finishes the first cause, which is COPD. I mean, the first cause of respiratory cause of breathing difficulty. So similar to COPD exacerbation, we have another respiratory cause, which is bronchial asthma. So here again, so we'll go fast from now. In bronchial asthma, the targeted history, patient will be having a history of bronchial asthma. There may be family history of bronchial asthma. There will be seasonal exacerbations present. And patient will be having a history of using inhalers. And here again, the history will be, this won't be taking days together. This will be a bit more acute than COPD because bronchial asthma is a reversible obstruction. So like patient may have history for 1 day. There may be some triggering factor like a dust exposure or a cold exposure or a climate change or a travel or some infection. So maybe in 1 to 2 days, they can develop the symptoms. And again, ECG will be normal. If you do an X-ray, X-ray also will be normal. In COPD, being a irreversible change, we can find out some changes in the X-ray. Whereas in bronchial asthma, you won't find any changes. So X-ray will usually be normal in bronchial asthma exacerbation. Here again, ABG may have type 2 respiratory failure, increased carbon dioxide, or it may have only a small hypoxia, or sometimes even ABG may be normal. So remember, this is one place where patient saturation will be normal, but still they'll be having breathing difficulty. So on examination, what you'll be having, bilateral air entry will be present. Trachea will be in the midline. Trachea will be in the midline. And we'll be having bilateral wheeze. So treatment here again is the same thing, inhaled nebulizers. But here the nebulization of choice will not be ipratropium. You can use ipratropium, but plain salbutamol or levosalbutamol may be enough. Plus inhalational steroids like budesonide may help. Suppose if still it is refractory, the same thing. Every 15 minutes, you can repeat an nebulization. Still present, you can give Diolin. That is, ipratropium also can be added. So this is about the nebulization. When IV steroid, as already mentioned, you can give 200 milligram of hydrocortisone stat initially. Maybe later you can change on to dexamethasone, which will be more specific. Then IV bronchodilator. Again, as discussed, derifilin, aminophylline, magnesium sulfate. So plus oxygen support initially may be given. Usually bronchial asthma will not go to non-invasive ventilation, but if at all it is severe, you can go for non-invasive ventilation. And ketamine, if it is refractory, if wheeze is refractory, then you can consider ketamine as an option. Usually you won't go to this stage. And adrenaline is a very important drug. So remember, adrenaline is not only a drug which is used in cardiac arrest. Like remember one mnemonic for adrenaline, ABCD. So A is for anaphylaxis. So any patient has taken prawn or fish and comes with an allergy. In a drug, they have come with an allergy. The first choice of drug will be adrenaline. So we'll have a separate discussion on allergies also. But remember, adrenaline is the first choice of drug in anaphylaxis. It is not hydrocortisone. It is not Avil. It is anaphylaxis because adrenaline is life-saving. B for bronchial asthma exacerbation. So this is one area where we don't use adrenaline often. But remember, if patient is having a very severe wheeze, they are going to the stage of arrest. Even in case of COPD or bronchial asthma, we can give injection adrenaline. So usually adrenaline comes as 1 ml ampule. The concentration will be 1 in 1000. We can give 1 ampule IM or subcutaneous stat. That will be fine. In anaphylaxis, usually give the same 1 ml IM stat. Because usually subcutaneous flow will not be present in anaphylaxis. So we prefer IM injection in anaphylaxis. If IV access is there, well and good. But in emergency, you can give IM for anaphylaxis. We give subcutaneous for bronchial asthma. The C in ABC is cardiac arrest. So that's not D, it's cardiac arrest. So ABC of adrenaline is anaphylaxis, bronchial asthma exacerbation, and cardiac arrest. So in cardiac arrest, you know the dose. The same thing, 1 ampule every 5 to 10 minutes. We can give IV. Okay. Okay. So this finishes COPD exacerbation, bronchial asthma exacerbation. So the next respiratory cause will be pneumothorax. Usually we say it as tension pneumothorax because mild pneumothorax will not cause respiratory distress. So tension pneumothorax, one side of the pleural cavity is filled with air so that it doesn't allow the lung to expand. So here, how will the vitals? Since the lung is getting compressed, it will also compress the nearby heart. So patients may come with low BP, saturation will be low, and they'll be in respiratory distress, obviously. And pulse rate will be very high. So what will be the history? It will be a sudden onset. So usually what may be the triggering factor is there may be some COPD or a cavity or some bulla in the lung. It may rupture spontaneously and air will collect in the pleural cavity. So this is usually sudden onset. So patient was apparently normal. He had a past history of some respiratory disease like COPD or a past history of cavity. In this case, definitely you should suspect pneumothorax. This is called a secondary pneumothorax. That is, patient is having some lung disease. Now they come with pneumothorax. This is called secondary pneumothorax. So any previous lung disease, suspect secondary pneumothorax. Very rarely, young people can present with something called as primary pneumothorax. That is, they may not have any previous lung disease, but still they are present with pneumothorax. But I think secondary pneumothorax we commonly see, and we should never miss this also. So any patient with respiratory disease who comes with breathing difficulty, especially COPD, don't think of only COPD exacerbation as a DD. It could be a tension pneumothorax if it presents sudden onset. That is why I was telling you initially, the targeted history should focus on onset, progression, and duration. COPD exacerbation is usually slow, whereas pneumothorax is usually sudden. So what examination? Trachea will be shifted. We have discussed previously. Plus air entry will be reduced in one side. Maybe if air entry is reduced in one side, you can do a few other examination. You can percuss the lung. Percussion will show hyperresonance. So this is just added things to confirm. Then you can do a chest X-ray. Chest X-ray will show full black color of one side of the lung, and the lung will be collapsed. ECG will not show that much of changes. ABG may show type 2 respiratory failure. So increase CO2. And how will you treat this? I told you about ultrasound. So we are not discussing ultrasound here. So Ultrasound also helps. There are few features like stratosphere sign. So how will you treat? A case of tension pneumothorax, don't wait for someone to come and put an ICD. ICD is definitely the definitive treatment. But what you can do as an emergency physician is needle thoracostomy. So as you know, air is something which collects above the lung. So when a patient is lying down, the topmost air spaces are the second to third intercostal space. So we can have the second intercostal space as the reference point. So in the second intercostal space, in the anterior chest wall, percuss it and confirm that there is air and insert a wide bore needle, that is green needle. Maybe a green Venflon needle or a green needle, just insert it. So when you insert, what happens if it is pneumothorax, all the air will come. Maybe you can connect that to an underwater seal. You can see bubbling which can come. So in fact, this is the main emergency treatment. You need not wait till someone comes to put an ICU. But intercostal drainage is the definitive treatment. But in an emergency, in front of you when the patient is collapsing, do an emergency tracheostomy. I think such a scene will come in a series called Money Heist. Money Heist, I think season 4, needle thoracostomy one scene will be coming there. But before putting a needle, the closest differential diagnosis for pneumothorax will be a bulla. In bulla in an X-ray can mimic like a pneumothorax. So always double confirm that it is a pneumothorax before putting it. Because if it is a bulla, we are putting a needle in the lung. We are not putting a needle in the respiratory cavity. So patient will develop pneumothorax later. So always differentiate between pneumothorax and bulla. If at all you have a doubt, you can go for a CT chest if the patient is stable enough to differentiate a bulla or a CT chest. Because as putting a needle in a pneumothorax is life-saving, putting a needle in bulla will be life-threatening, right? So we'll stop with the ICD and needle thoracostomy. So same scenario, the fourth cause will be pleural effusion. The pleural effusion, as I told, is accumulation of fluid in the pleural cavity. In a setting of acute trauma, accumulation of blood in pleural cavity is called hemothorax. So hemothorax will be acute, sudden onset, whereas pleural effusion is usually slow. So this lasts for days together. So here again, patient will be in respiratory distress. Trachea will be shifted. There will be absent air entry in one side. Here, if you do a percussion, in pneumothorax, we'll be having a resonant note. Here, we'll be having a dull note. Usually, massive pleural effusion will not be that an emergency. So you need not interfere very much soon because patients usually won't be sick as it is very slowly progressive. So do a chest X-ray. It will show whitened out lung. Usually, there will be time to evaluate in a case of pleural effusion. So here again, the definitive treatment is ICD, or you can do a large volume drainage. So that will be the treatment. So bronchodilators or steroids will not have a role in these two conditions. And fifth condition, maybe you can tell acute respiratory distress syndrome or a pneumonia. Like patient had a lung infection, he comes with a breathing difficulty. X-ray is showing a bilateral increased opacities. ECG is normal. Trachea is in the midline. Suspect a pneumonia or an ARDS. Here again, the treatment will be the basic supportive ones, giving oxygen, back rest. Maybe you can give a bronchodilator. Usually, ARDS will need a non-invasive ventilation. There are few settings for that. I think from your perspective, starting oxygen or NA will be fine in ARDS. So these are the common respiratory causes for respiratory distress. Cardiovascular causes are very simple. A myocardial infarction can present with a chest pain plus a breathing difficulty. So this will be discussed separately again in chest pain while discussing chest pain. But remember, a sudden onset breathing difficulty always needs an ECG. That is what you should remember. So don't just think it's a breathing difficulty, so I'll take an X-ray. A sudden onset breathing difficulty always needs a ECG, because sometimes pulmonary edema or breathing difficulty is called as angina mimic. Breathing difficulty can be a presenting manifestation of a myocardial infarction. So in that case, you have to give a treatment for myocardial infarction, which we'll be discussing later. Plus, why the patient is having breathing difficulties because of pulmonary edema. Because with MI, the heart cannot pump properly. So the back pressure will go from the left ventricle to the left atrium, from the left atrium to the pulmonary veins. Hence, lungs become congested. So how will you treat pulmonary edema? The most important thing is back rest. The most important thing to treat pulmonary edema is back rest. That is, never allow the patient to lie down. Because what usually happens is patients will be having a chest pain or breathing difficulty, pulmonary edema in the home. They'll be brought in an auto or a car to the hospital. And when they're shifting the patient from the patient's vehicle to the stretcher, sometimes people forget to raise the backrest in the stretcher. They make the patient lie down. As I already told you, any patient who's not able to lie down will definitely have a cardiac disease. So cardiac patients cannot lie down. When they lie down flat, they'll immediately develop a pulmonary edema. They become sick. Sometimes they can go for a cardiac arrest just at the entrance of the hospital. So please be sure, any case of respiratory distress, try to receive them with a backrest. Okay, you would have learnt in trauma the golden rule. Never mobilize the spine. Never mobilize the neck. So unless you have ruled out a fracture, any patient with a trauma, don't move the neck. There's a separate technique called on and off technique. On and off technique to shift a patient to a stretcher in the case of suspected spine injury. Similarly, any patient with a suspected breathing difficulty, if you're having a doubt of pulmonary edema, never shift them without a backrest. Patients can go for a cardiac arrest in front of you. So this is the most important first thing which you should give. Then start oxygen. They may need non-invasive ventilation. This is usually a type 1 respiratory failure, as we have already discussed. And the treatment here is diuretic. So what diuretic we commonly use is furosemide. Dose varies. Maybe we give 40 milligram IV stat. We can repeat the dose, even up to 200 or 240 milligram can be given based on the response. Like if the patient is needing a large volume of Lasix diuretic, then straight away they can be put on non-invasive ventilation. Then the fourth thing is correct the cause. Myocardial infarction can lead to pulmonary edema in the acute setting, and uncontrolled hypertension can lead to pulmonary edema. So any patient who comes with uncontrolled hypertension and pulmonary edema, the treatment is not only diuretic. So give diuretic to treat the pulmonary edema, but at the same time, we have to give some medicines to reduce the BP also, like injection labetalol. I'll tell you the dose of labetalol also. So among most of the drugs, I think labetalol is a safe drug to give in acute hypertension. Just remember this dose. Give 20 milligram IV stat. Watch for 15 minutes. BP is not controlled, double the dose. Give 40 milligram IV stat. Status should be given over 2 minutes. Should be diluted and given over 2 minutes. Again, wait for 15 minutes. If BP doesn't come to the target, then it should be double, 80 milligram. Then still 80 milligram. 80 milligram. So 20, 40, 80, 80, 80. So total maximum dose is 300 milligram of labetalol in the acute setting. Later on, it can be continued as an infusion. But remember this dosing regimen for labetalol. So if it is hypertension, give labetalol and diuretic. And third thing is just a manifestation of cardiac failure. So as I already told you, a patient with a chronic coronary artery disease or a post bypass grafting, he would not have taken the medicines properly, or he would have taken more of fluids. Instead of fluid restriction, he would have taken more of fluids. That failure itself could be a presentation of pulmonary edema. But usually, in the acute setting, a cardiac thing is pulmonary edema. Try to rule out whether there's an MI or an uncontrolled hypertension. And maybe in myocardial infarction, you can give injection morphine also. So morphine will usually be diluted. So 1 milligram or 2 milligram IV morphine will have pulmonary vasodilation effect and it will treat pulmonary edema. So I think this is the commonest cause of cardiac cause of respiratory distress, which is pulmonary edema. Now comes the most important thing. Their cardiac examinations and what examination finding you will get in pulmonary edema, it is crackles. Bilateral basal crackles of the lung, trachea will be in midline, cardiac there may be S3. Now comes the next important aspect. Suppose patients cardiovascular examination and respiratory examination both are normal. In this case, what are the things you should suspect? Remember, I told you one scenario which we are discussing. Patients had a mild hypoxia, comes with respiratory distress. Cardiac examination, respiratory examination is normal, but he is in respiratory distress. That's a hypoxia. So this is your case scenario. So the first thing which you should suspect, lungs is clear, chest is cardiac is clear, but still patient is having hypoxia and respiratory failure. Always rule out pulmonary embolism. The case which we are discussing is pulmonary embolism. Okay, they may present only with tachycardia, sinus tachycardia. X-ray may be normal. There may be lung infarct, but X-ray is usually normal in pulmonary embolism. ECG again, you may not have the typical feature. They say S1, Q3, T3 as a pattern, but usually we do not see S1, Q3, T3. ECG will show only sinus tachycardia. So a patient with a history suggestive of pulmonary embolism, like a bedridden state, a history of deep vein thrombosis of the leg, comes with sudden onset breathing difficulty, with a normal chest, normal lung, cardiac examination, usually suspect pulmonary embolism. So suppose if you are having a pulmonary embolism, again give oxygen. If possible, try to do CT pulmonary angiography. CTPA is the test of choice. If you are not able to go for CTPA, we have blood test called D-dimer. So we are discussing in the investigation, right? We have to send D-dimer. If D-dimer is positive, then mostly it is pulmonary embolism. We have two options. If patient is sick, hemodynamically unstable, treat like MI, thrombolysis. The pulmonary embolism, thrombolysis. Suppose if they are stable, give heparin. Okay, so pulmonary embolism. So the breathing difficulty with normal lung, one is pulmonary embolism. The second one is cardiac tamponade. So I was telling you, if heart sounds are heard, that is well and good. If S1 and S2 is not heard or if it is muffled, in the case of breathing difficulty, always suspect pericardial effusion or a cardiac tamponade. Here again, we won't have much role. So this is confirmed by doing an echocardiogram, bedside echocardiogram. All the cardiologists and pigtail drainage is done. Or needle drainage is done. So usually we don't do cardiac tamponade. If you are interested or if you are practice that, it is okay. So this is the second place where most of the examination seems to be normal. Patient is in respiratory distress. Third reason will be metabolic causes. Metabolic cause of breathing difficulty. Example, this also we have discussed. Any acidosis, diabetic ketoacidosis, CKD with acidosis. In few poisoning. So yeah, most of the poisoning will present with high anion gap metabolic acidosis. Like even patient has come with heavy alcohol consumption or some poisons like paraquat poison. Any acid poisoning like phenol poisoning, they'll present with breathing difficulty. So this again a short history. They'll come straight away with history of consuming some poison. Or when you suspect this patient is having breathing difficulty, there is acidosis, you are not able to rule out things, ask this one. So DKA, CKD, and poisoning. Acidosis is a cause. Suppose if your chest is clear, lung is clear, then always never forget to look out other sources. Sometimes patients may have a ruptured duodenal ulcer and they may be bleeding from the abdomen. So because of that anemia, acute anemia, they may be having a breathing difficulty. When you examine, they'll have tachycardia. Their saturation may be normal. You'll be looking repeatedly at the chest X-ray and ECG, it may be normal. But you may have missed something, some bleeding which is going on within the abdomen. So if everything is normal, if the ABG did not show any acidosis, and if you are not having a suspicion of pericardial effusion, then never rule out abdomen. Abdomen is always called as Pandora's box. We don't know what is going on inside unless we open it. So if you are not able to find out the cause of breathing difficulty, please look at the abdomen. Right? So I think this finishes one major topic of approaching the emergency approach of breathing difficulty. So in short, assessing breathing difficulty is easy. So they'll be using accessory muscles or respiration signals. They may be unable to lie down. And when they come to you, give a backrest always, give oxygen, start assessment initially. Assessment is just ask their comorbids, what is present, ask the duration of onset, progression and duration. And targeted examination will ask about associated symptoms. Targeted examination will be about whether trachea is in midline, whether air entry is equal in both sides, see about the added sounds, and look for basal crackles, look for S3 in cardiac examination, and send for ECG, chest X-ray, ABG initially. Later on, you can ask for an ultrasound, echocardiogram, D-dimer, cardiac enzymes, pro-BNP, which can give you about various etiologies. And we discussed about respiratory causes and cardiac causes and non-respiratory, non-cardiac causes. Okay. Any doubts or discussions?
In pulmonary embolism, how to give heparin?
Usually in first 48 hours, we have to give heparin as infusion. That's a dosing called as 18 units per kilogram per hour infusion. So like usually it will come around 1000 units per hour. So dilute it in normal saline and you give us 1000 units per hour infusion for 48 hours. And then you can change to 5000 units subcutaneous or IV Q630. So initial 48 hours was infusion, then as Q630.
Okay, sir.
Okay. In some mild cases, they'll be giving oral anticoagulation, but I think this is commonly practiced. Suppose if they are, the decision of thrombolysis is usually made by some consultants, but I think heparin can be started. Whatever it is, even after thrombolysis, you have to continue heparin. And heparin will be life-saving in that situation. So you can understand this dose. 1000 units per hour followed by. Okay. If there is no other doubt, we'll close this session. So this is how we'll be approaching the future classes. So we'll be taking a particular complaint. With an example of the patient, will be approaching their targeted examination and assessment and their causes with the basic treatment. So see you in the next class.
Thank you, sir.